at all.
I've started the webinar and people are filtering in. We're now at 34 or 40 participants.
Fantastic. So I'll just wait for that to stop increasing, and then we'll get started. So hello everyone, thank you very much for joining us today. We're just waiting for a few more colleagues to join, and then we'll get started with today's event. Okay, fantastic. We're more than 100 people, which is fantastic news. So thank you everyone for joining. So yeah, let me get started. My name is Jamie Bridge. I'm the chair of the Vienna NGO Committee on Drugs. We are a global committee of non-governmental organizations. And really our main role is to link civil society with the UN processes and the UN agencies when it comes to drugs, and particularly the UN agencies based in Vienna. And with that in mind, we're really happy to be co-hosting today's webinar, which is looking at the World Drug Report 2021. So the World Drug Report is an annual report produced by the United Nations Office on Drugs and Crime. It's the global compendium of data and information related to drugs and everything related to drugs. It was formally launched a few weeks ago on the 25th of June in Vienna, and also I believe in New York. And we're really, really pleased to have UNODC's research branch here today to present the report to us, to go into a bit more detail about some of the findings and the messages, but also to allow for some really important discussion as well. So before we get started, just a few quick housekeeping things before we start. So first of all, we have translation today. We have interpretation available in French and in Russian. So please, if you see at the bottom of your Zoom screen, you should see a link called interpretation, and there you can select your language. And you may also want to mute the original audio, which will allow you to only hear the translation that comes through. So please, even if you want to follow this in English, please select English as your language, so that if there are any interventions in another language, they'll be translated back for you. So that's the first thing. If you have any issues or problems, please let us know in the chat. Please also use the chat to introduce yourselves and to let us know who you are. Really happy to have so many people on board. We're now around 130 participants, which is great news. But we are going to have time for question and answers with our expert speakers that we have today. But I would urge you, please, if you have a question, please submit it using the Q&A box at the bottom. Please don't put your question in the chat, because the chat moves so quickly. It's quite easy for us to lose a question. It's hard to follow that as well. So if you have a question, please use the Q&A, and either we'll try to respond as we go, or we'll have some time for that question at the end. So that's it, I think, from my side. Oh, and just to say, sorry, one more thing. We are recording today's event as well. That's just so that colleagues around the world can also watch this, even if they're not able to follow it today live. So just to let you know that we are recording. So without further ado, it's my great pleasure to hand over to Mirella Dumafrahi, who is the chief of the UNODC Civil Society Unit. The CSU is a long-term ally of Vienna NGO Committee, and we're co-hosting this together with them today. So Mirella, over to you to say a few welcome words.
Thank you, Jamie, and welcome to everybody. I'm really very pleased to see how many of you have joined this event that we have started in a difficult time last year because of COVID, but at the end it sounds like a good idea. We will certainly continue because not everybody can follow the formal launch, and especially we have the opportunity to use less official technology. Let's say with Zoom we can have the interpretation, while at the UN it would be a bit complicated to have interpretation in a non-formal meeting. Welcome everybody. I have the privilege to chair to lead the Vienna the civil society unit. I was going to say the Vienna NGO committee, who is actually our counterpart from civil society when it comes to drug. The way we work in the civil society unit, we have umbrella organization. So for drugs, we have been working with the Vienna NGO committee for so many years, and I'm very pleased that we are co-organizing this important event today with them. The World Drug Report is really, I would say, and more modestly, even if it's a UNODC international flip chart publication, is really the most well-known publication on drugs and the most probably reliable. In any case, I have worked also in the past as a press officer, and really this is one of the publications which is mostly covered also by the media. It was presented, as Jamie said, at the Commission on Narcotic Drugs on 25th of June and to the journalists on 24th of June. But there's so much, and I'm sure that you may have had the opportunity to read it, but here it is great to have the research branch with us, UNODC Research and Analysis Branch. We are in the same division, but in completely different departments. And I think I will not say more because it's more interesting to go directly into the substance, but just to say that we will hold the second webinar focusing on the latest trends in Africa and America on Thursday with in the afternoon to make sure that the Americans can follow us. And this time we will have Spanish interpretation. This time it's focusing more on Asia and the Pacific and Europe. Again, we believe that civil society can play an important role when it comes to translating policy into action, and the World Drug Report is a valuable tool to provide scientific data, trends, facts that an organization can use in their daily work. You can further share this important publication after the meeting, and also remember that we have a joint tool, which is where we exchange practice and showcase. It's the NGO marketplace. Later we will put also the link on the chat in case you are not part of it, you would like to join it, please do join. So without further ado, I think Chloe, if you want, Jamie, I can introduce Chloe, who is the chief of the drug research section, and she will be followed by other colleagues, but then I will leave it to you, Jamie, to introduce the other one.
Yeah, just to say, sorry, Chloe, just very quickly, we are aware that there seems to be a slight problem with the Russian translation. We are trying to fix that, but Chloe, you carry on, and we'll post in the chat once we've managed to resolve that challenge. Thank you.
Okay. Good morning, everyone. Thank you, Jamie. Thank you, Mirela, for your kind words and the introduction of the World Drug Report. So I will give everyone here a brief overview of the key findings, some of the key findings. The report is very rich, there are 5 booklets. It's very long. I think is the richest we have ever done. So there is plenty to discover if you're curious after my intervention and after the intervention of my colleague Thomas Pichman, who will follow later on with more details on what's happening in terms of situation and latest trends in drug markets in both Europe and also Asia and Oceania. So I will keep at global level, so give you a sort of framework for where we are in terms of key findings. So perhaps the first one I would like to share with you is related to cannabis and the fact that cannabis products have almost quadrupled in strength in the United States and have doubled also in strength in Europe in the last decade. Let me just adjust my screen because I don't see my slide. In the last 2 decades. And why this is an issue? This is an issue because we know that THC, data-9-THC, the psychoactive substance in cannabis, is responsible for the development of mental health disorders in long-term heavy users of cannabis. And yet, the percentage of adolescents perceiving regular use of cannabis as harmful has decreased. And we see here by as much as 40% during the same period. And this is the graph on the right. So there is really a mismatch between the perception and the reality of the risk posed by more potent cannabis. And this is of particular concern since evidence also suggests a link between a low perception of risk and higher rates of usage. And this is not only the case in Europe and United States, it's also the case in other parts of the world. Now, the second key finding, which I would like to share with you, is related to the online sale of drugs or distribution, and in particular in relation to the use of the dark web. Drug markets on the dark web have emerged about a decade or so ago, so this is relatively recent. We see here with the graph at the bottom of the slide that they are extremely volatile because of law enforcement action, but also because of exit scams. But what is very interesting is that the main ones, these main markets on the dark web, which are distributing drugs, are now worth at least 315 million.
Sorry to interrupt you. Can we just wait a minute because there is a problem with the Russian interpretation and we would like to try to fix it. Just 2 minutes, sorry about that.
George, can you hear us? Because can you hear us? I'm in the Russian channel, but I cannot hear you. You are very, I can only hear background noises from you. Hello, yes, now I can
use
hear
the
you.
mic and
can you make sure to interpret into Russian because we haven't been able to hear you for a while. Okay, so you can start interpreting now. Is that fine?
Can you interpret now what I am saying? Yeah, in Russian, please, to make sure we can hear you. Can you say in Russian what I'm saying?
Okay, great. We are starting now.
But you know, we are waiting. I want to try. Can you try to interpret? I cannot hear
if we can hear the
Russian.
translator now, then that means the channel's working. So, Chloe, I think you can get started now. And yeah, apologies to all those colleagues who were waiting for the Russian translation. We've managed. I can now hear the translator in the Russian channel. So, Chloe, if you carry on, and then we should be working. Thank you, everyone.
Do you want me to start again?
I think if you could briefly recap the cannabis slide, I think that might be useful just for those who might have missed it, because I know we have a large number of Russian speakers with us today. Thanks, Chloe. Okay. Sorry about that.
Thank you. So the first key finding that we wanted to highlight is related to cannabis and to the fact that we see that the strength of cannabis product has increased quite a lot. As multiplied by 4 in the United States, doubled in Europe in the last 2 decades. And we know that the fact that the psychoactive substance in cannabis, data-9-THC, which is the strength of cannabis, is responsible for the development of mental health disorders in long-term heavy users of cannabis. But yet, we see that the perception of risk of using cannabis regularly, the risk as harmful, has decreased among adolescents. So there is really a mismatch between the perception of the risk and the reality of the risk posed by more potent cannabis. And this is really a concern because there is also evidence that suggests that there is a link between low perception of risk of use of a substance and higher rates of usage. And this is not only the case in Europe and United States, but also in other parts of the world. So this is the finding related to cannabis, which is one of the key findings of the report. Now, the second one that I wanted to highlight is related to the online sale or accessibility or distribution of drugs. And in particular, in relation to the dark web. The drug markets on the dark web have emerged about a decade ago or so. They're very volatile, as you can see in the graph below, because of law enforcement actions, but also exit scams. But what we see now is that these main markets that are selling drugs on the dark web are at least worth 315 million in annual sales. Now, this is really a tiny fraction of overall drug sales, less than 1% actually. But the trend is upward. And this is what I think we need to monitor. We need to keep an eye on. There's been a fourfold increase in annual sales compared to the beginning of 2010, basically. But the expansion of online drug market is not only confined to the dark web. But this is something that we have also discussed in the World Drug Report this year. This is new. We see that the use of social media and popular e-commerce platforms further suggests that accessibility to drug markets is widening. So of course, cannabis and other controlled drugs dominate sales on the dark web, and on the clear web, what we see is less of controlled drugs, or very rarely, but mostly new psychoactive substances, so drugs which are not controlled, and also the sale of substances which are used in the manufacture of synthetic drugs, including precursor chemicals, some controlled, some not. Now, what we see is that vendors are playing a cat and mouse game with law enforcement by marketing their products as research chemicals, or advertising what we call custom synthesis. This is, which is basically clients can request substances that are not included on the lists of available products, and they can request whatever they want, basically. And this is clearly a legitimate practice in the pharmaceutical industry, but it may be misused by traffickers to distribute controlled substances. So this is what we see on the clear web, basically. Now, the third key finding, which I would like to share with you today, is related to an exercise of projection that we conducted this year to see how demographic changes alone will impact on the number of people who use drugs by 2030. So what we project is that globally, by 2030, there will be an increase of the number of people using drugs by 11%. At global level, and just because of demographic changes. And this rise in people who use drugs is predicted across the world, but it's likely to be particularly pronounced in Africa. Here, the growth is projected to be about 40%. So this is really a lot. Now, we see that low-income countries account for the lion's share of this rise, because their population is younger, and it is projected to grow much more than in high-income countries where the population is comparatively older and is projected, in fact, to decrease even. But what is really of concern is that in low-income countries, there will be a major increase in young people in the next decade, not only in the population in total, but also in young people. And this is an additional concern because drug use is higher among people who are younger, basically, especially, I would say, 15-35 or 20-35. Now, the last set of key findings that I would like to highlight today is related to the impact of the COVID-19 pandemic on the drug problem. So what we have seen is that drug markets were temporarily disrupted in most parts of the world during the first phase of the COVID-19 pandemic. but they have recovered rather quickly, I would say. And what is interesting is that, yes, they have recovered quickly, but the pandemic has triggered or accelerated some pre-existing trafficking dynamics. So this includes the fact that shipments of drugs are becoming larger and larger, that there is an increasing use of land and waterway routes, also general aviation, private planes, also air cargo, and also postal parcels, and of course, an increasing use of contactless methods for delivering drugs to consumers, including through mail delivery, but not only. Now, in terms of the use of drugs, most countries have seen an increase in the non-medical use of cannabis and the non-medical use of pharmaceutical drugs, such as benzodiazepines during the pandemic. The changes in patterns of use of other substances have been less clear, but for drugs such as ecstasy and cocaine, drugs which are typically used in social settings with other people, there are reports across the board that they have been used less frequently during the pandemic, of course, because of less opportunity to use them and to meet people. Now, another trend during the pandemic in North America this time is a spike in opioid overdose death since the onset of the pandemic. And perhaps another thing I would like to mention here is that many of the measures related to the containment of the COVID-19 pandemic are known to have increased economic deprivation and feelings of social isolation, which are factors that can contribute to increased drug use. Now, there has been, in terms of perhaps drug use prevention and drug treatment services, what we see is that in many countries, there has been a major disruption in the early stages of the pandemic in terms of the delivery of these drug use services, I would call them. But then after a while, what we have seen is that many tasks that were once conducted face-to-face have started to be carried out using internet-based technology, using telephones or the postal system. And in some countries, we have seen even rapid innovation, which has transformed what health professionals treating people who use drugs can offer. So there's really been some innovation. With the introduction, for example, of telemedicine to comply with stay-at-home measures and physical distancing rules, for counseling and also initial assessments over the telephone. So not only for the general population, but also for people who use drugs. So this is very interesting. In some countries also, there has been a simplification of prescription requirements and also more flexibility with opioid agonist medication. And some people suffering from drug use disorders have also been allowed to take home methadone doses. So this is also an innovation. And we have seen vending machines being set up to dispense opioid agonist medication, and also the use of postal services to distribute clean needles and syringes. So of course, many of these novel approaches will need to be evaluated to better assess their effectiveness, and also to assess whether some of them should be mainstreamed in the post-pandemic phase, I would say, in the range of delivery options for drug use services. Now, if we look a bit in the medium term, I think what we see that the pandemic has brought increasing economic hardship along with a radical shift in technology and dramatic alterations in social habits. And all this is likely to affect drug patterns in the long run, both on the supply side and on the demand side. So we see that fragile communities in both opium poppy cultivation areas and coca bush cultivation areas have become increasingly vulnerable as the pandemic has affected their livelihoods. So this will only increase the appeal of illicit crop cultivation. And in terms of trafficking, unemployment is rising, and it means also that drug traffickers will find recruitment easier in a time of economic hardship. And at the same time, we see that inequality, poverty, and mental health conditions are on the rise across the world. And these are non-factors that may push people into drug use, but also increase negative health consequences of drug use, and also rise in, may lead to a rise in drug use disorders. So the picture is not really rosy, I would say, in the medium term, the post-pandemic phase. Now, if I move to more traditional findings, and I have 2 slides about that, I would like to mention that the number of people using drugs has increased by 22% in the last decade to about 275 million. And those suffering from drug use disorders has increased even more by 33% during the last decade to about 36 million people. But what we see is a sort of stabilization in the recent years, but we need to be also very cautious about these trends, because this represents basically the best estimates for each year. So we need to see, every year, we need to see what are the best estimates that come up from different countries across the world. Now, in terms of the burden of disease, it remains very high among people who use drugs, and in particularly among those who inject drugs, which is estimated at 11.2 million in 2019. Half of these people who inject drugs are living with hepatitis C, 1/8 are living with HIV, and just a bit less are living with both hepatitis C and HIV. And in terms of the number of deaths and the years of healthy life lost due to drug use, they both continue to increase. They were close to 500,000 deaths in 2019, and 31 million years of healthy life lost due to disability and premature death caused by drug use in 2019. And opioids continue to account for the largest global burden of disease attributed to drug use. It accounts for 71% of them. So this is a very high proportion. It's stable, basically. It was also very high in previous years. So we don't really see much of an improvement here. Now, I will finish on this slide, and perhaps the comment that while the world drug problem is clearly a common challenge across the globe in different regions, there are clearly local dynamics. So what we have mentioned here is that cannabis, both trafficking and use, affects all regions worldwide, but there are specific issues that affect different regions, perhaps more particularly, in addition to cannabis use and trafficking. So you see here, for example, in green, that cocaine is mainly an issue in the Americas, but also in some parts of Africa and Western and Central Europe. Methamphetamine is mainly an issue in East and Southeast Asia and North America, and perhaps opiates, mainly an issue around Afghanistan, but also in Western and Central Europe, etc. So this will be my last slide, and Thomas Pitchman, who is part of the team who is drafting the World Drug Report, so is one of the main analysts, will uncover for you the details about the latest trends regarding the different regions, and particularly regarding Europe and Asia and Oceania, which is the focus for this meeting today. Thank you very much. I encourage you to look at to dig into our website, to dig into the 5 booklets of the World Drug Report. They're all published in English. The first one, Exif Summary and Policy Implications, which is a summary of the main findings throughout the other 4 booklets, is already translated in the 5 other languages, official languages of the UN. So I invite you to go there and to learn a bit more, perhaps. And later we will make available on the site the translation of the other booklets. Thank you very much for your attention.
Thank you so much, Chloe. That's a fantastic summary of what is a incredibly complicated and comprehensive set of data and reports. So we put the link in the chat. I do encourage you, as Chloe says, to visit the website, read the reports, but also kind of interrogate the data that's been made available by the UNODC research branch. So thank you again, Chloe. So what we're going to now, I'm really pleased to have Thomas Pitchman here with us as well. So we're going to give the floor to Thomas, but just to say we are aware that the Russian translation still isn't working as we'd hoped. I don't know, Sarah, is there any update on this, or is there anything we can do?
Yeah, it would be great if we could test this again. The Russian interpreter is online.
Okay, so before we go to you, Thomas, can we please test the Russian again? Because it was working when we paused you, Chloe. So I'm not quite sure why it's now stopped again. So Sarah, I'll hand over to you.
Can you interpret us? Are you hearing us? Say it in Russian, please, if you are hearing me. So how? And so you could not hear Chloe. You could not hear the previous interpretation. Please do say it in Russian.
The next speaker will be Thomas Pitchman. He will also have a PowerPoint presentation on the World Drug Report, as I sent around in my email communication with Tremeles. So if you can interpret what you hear, please.
You're supposed to interpret into Russian, huh?
Okay, so we're going to hand over now to Thomas Pitchman, who's going to give his presentation. We can hear the Russian translator, so we hope that this presentation will be translated for us into Russian. Thank you to our, and please, if you could start translating me as well, please, translator, so that people can understand, because I want to say thank you to our Russian colleagues. So I'm in the Russian channel now. I can't hear any translation. Are you able to translate into Russian? Hello?
Could you at least say that we very much regret for our Russian? Maybe Katerina, can you jump in and say?
I need to make her a panelist, Katerina.
Okay, we will say it at the end then.
Okay. But sorry, so to the Russian translator, can you start to translate me into Russian, please? Okay?
We don't hear you.
I can't hear anything. Okay, unfortunately, we're going to have to move on. I'm really, really sorry I don't know what's going on. I think it's a confusion rather than a technical problem.
I'm adding Katerina now.
So yeah, okay, let's continue, because I don't want to keep us waiting, because we've got some great speakers lined up as well. So yes, so Thomas, please, over to you. So what's going to happen now is we're going to hear from Thomas, who's going to give us a more detailed summary of the data and findings from Asia Pacific region. We'll then hear from two of our selected civil society speakers, Dr. Salih and also Smitra Rana, who are going to give their perspectives as well from Afghanistan and from India. And then we'll go back to Thomas to hear a summary of the data from Europe. And then we'll have time for Q&A at the end. We will continue to try and fix this problem, this misunderstanding with the Russian translation. But in the meantime, Thomas, please, happy to hand over to you. Thank you.
Thank you very much. So I try now to share my screen. Can you see my screen? Sorry, can you see my screen, please?
No, not yet, Thomas. No, I can just see you.
The share screen. Can you see my screen?
Yeah, I can see the screen. If you want, I can see presenter mode right now rather than the slide set.
Sorry, you don't see the presentation?
I can see the presenter mode, so I can see like your notes and things like this rather than the actual slide.
How do I do this again?
Thomas, if I may, you have an option on the top of the screen which says switch display settings. And here
Yeah.
you,
When I start,
now display settings, and there, yes.
Yeah.
Yeah, you go there, and then you
Swap.
swap presenter view, and this is okay. It should be okay.
Okay, now can you see it?
Now you need to click.
Can you see?
No, we see the presenter mode.
Sorry, I start again. This is stupid, sorry. Resume share. Or sorry, what do you see now?
I see your like the main PowerPoint window with all the slides down the side.
Okay, and now?
Yes,
And now I
this is
see the
fine.
slide. Yeah.
Perfect, thanks a
Good.
lot.
Thanks, Thomas. Thank you.
Okay, I will focus on Asia and Oceania. So first of all, the opioids, what is the most problematic drug at the global level, plus particularly when it comes to Asia. We have the two centers. This is Afghanistan producing and exporting, and we have Southeast Asia, Southeast Asia, Myanmar, and exporting. This is two centers, and the main trafficking routes continues to be the Balkan route going from Afghanistan to Pakistan, to Iran, through Turkey, the Balkan countries of Western Europe. We have another very big market, it's South Asia itself. So India has become a very big market, also supplied from Afghanistan. And we have got Southeast Asia, mostly supplying East Asia, here and particularly China. Now, in terms of the global problem, we had an increase in the area under cultivation. Good news was we had still a tiny reduction in production, basically because of bad weather conditions in Afghanistan. Having said this, you see over the last few years, Afghanistan has been rather stable, but really very, very high. Now, when we compare to the overall 2019 was the last comparable data, 84% was Afghanistan, 7% of global production was Myanmar, and 6% was Mexico. So these three countries together account for almost 97% of global opium production, and thus is also of the raw material for the production of heroin. And if you just look at Asia, it's clearly more than 90% of the opium production takes place in Asia. In terms of the seizures, what we see here, more than 60% is Asia, and the dominance is here the near Middle East, Southwest Asia, 45%, followed by East and Southeast Asia, 9%, and then followed by South Asia, so basically India. In terms of the countries, the opium is mostly seized in Iran, Pakistan, Afghanistan, the morphine in Iran, Afghanistan, and Pakistan. And when it comes now to the heroin, the biggest was Turkey, but then we had Iran and Pakistan, and later on China, Afghanistan, and India in Asia, Azerbaijan, and Sri Lanka and Vietnam. In terms of the pharmaceutical opiates, there's something interesting that really there has been a massive increase in Asia. So most of the pharmaceutical opiates used to be seized in Africa. Now it's Asia. And the dominance, so this is the red bar, which is really, really increasing. Clearly more than 50%, 60% takes place in Asia. And this is particularly, we are speaking here of cough syrups, of codeine cough syrups, which have been extremely widespread on Asian territory. Now, another issue is the availability of opioids for medical use. And here we see the biggest availability is North America, but then comes Australia and New Zealand. But if you look at the Oceania, it's Melanesia, Polynesia, and Micronesia is very low. So within Oceania, a big difference between on the one side, Australia and New Zealand, on the other side, Melanesia, Polynesia, and Micronesia, where it's clearly far too low. There are also people who are suffering, and those people in practice don't get access to medicines, to opiate medicine, which they would need. When it comes to Asia, the region which has the highest level of pharmaceutical opioids is the near Middle East. Here's particularly Iran, which is high. then followed by East and South Asia, Central Asia, and the Trans-Caucasus, and finally South Asia again being very low. All of these areas are still below the global average. So Asia is below the global average, but within Asia, there's one region which is close to the global average, and this is the Near and Middle East. Now, at the global level, we see again the changes. Australia and New Zealand rather stable over the last 4 years. Then we see in the other parts of the Oceania extremely low and even declining. So there's a massive lack of access to medical opiates in this part of the world. Rather high in contrast, but relatively high, is the Near Middle East. And there we had seen an increase over the last few years, much more than in other regions in Asia. Now, when we come particularly to methadone and buprenorphine, you know, the substances which are used for treating heroin addiction, you see rather high levels in Australia and in New Zealand. Here's particularly so methadone, less so buprenorphine, and again, extremely low levels in Melanesia, Polynesia, and Micronesia. And you see rather high levels in the Near and Middle East, even slightly above the global average. This is particularly methadone, which is found there. But the other parts of Asia are again clearly below the average. And we speak about Central Asia, East Asia, and South Asia. And South Asia is a little specific because in South Asia, it's particularly buprenorphine. In other parts, it's methadone, the most substance you find on the market. Next issue, amphetamine type stimulants. Here we see a global increase over the last couple of years, particularly starting with methamphetamine, who has been skyrocketing over the last 20 years, and particularly over the last 10 years, and in particular in 2019. Now, in terms of the countries affected, it is really high in East and Southeast Asia, and then second, Near and Middle East and Southwest Asia when it comes to these substances. Now, when we come to methamphetamine supply only, you see in green, these are the seizures of East and Southeast Asia. So you see basically North America and East and Southeast Asia are dominating. There is where the market is. However, in terms of the laboratories dismantled, you see 85% dismantled in the Americas, and Asia less than 6%. So you see that there is very small numbers of laboratories dismantled. At the same time, we have to say many of the laboratories which have been dismantled in Asia have been big, large laboratories. Many of those in Americas, particularly the United States, have been very, very small ones. So it's not directly comparable, but still it's an issue that in terms of law enforcement, laboratory dismantling, there is still a lot of corruption in some of these countries, and these laboratories don't get dismantled. In terms of the seizures of methamphetamine, we see clearly United States, but followed then in Asia by Thailand, and then high levels in China, Myanmar, Indonesia, Iran, Laos, Malaysia, Vietnam, and then smaller ones, Bangladesh, and Japan and Philippines, and also India. And then we have Australia and New Zealand for comparison. In terms of the methamphetamine seized, we see the massive increase over the last few years in East and Southeast Asia. However, within that, there has been some interesting phenomenon, and this has been a decline of the market in China and an increase of the market in Thailand and neighboring countries. On the other hand side, there has been also a massive increase in methamphetamine in the Middle East and Southwest Asia, mostly Iran, but the big increase now in terms of production has not been Iran, the big increase has been Afghanistan. So we have now the methamphetamine not only being produced in Iran, but really being produced in Afghanistan. And the specialty is here, there it's not produced out of ephedrine or pseudoephedrine, which is normally done in Asia. There it's produced directly from the ephedra plant. The ephedra plant you find in Afghanistan, it's been converted into ephedrine, and out of this, then the methamphetamine is being produced. And what is interesting, the prices, a comparison, we looked at the prices in Afghanistan are 1/10 of the prices in Myanmar. And Myanmar is not expensive, but it's really cheap because you can produce it out of ephedra. So next to opium, there's a big problem in Afghanistan with the production of methamphetamine, which is now spreading across the country. In terms of Australia, New Zealand, we see was a big increase until 2014, then a stabilization, even a small decline. However, in terms of consumption, there was wastewater analysis taking place in Australia. We've seen a clear massive increase from 2016 to 2019, and only 2020, again, a small decline, which seems to have been linked to the COVID pandemic. Still in Australia, particularly high, the interception rate, what we find is 26%. This is really very good news, very good, very high compared to many other countries. 26% of the methamphetamine which enters the country or is produced there actually is being seized by the authorities. In terms of the amphetamine, there's been also a clear increase over the last 3 years. And here is one thing I want to dominate, interesting is the Near Middle East. You see it in purple. There has been the market, the Near Middle East. This is the big market, the developing market for the amphetamine trafficking, and particularly so-called Captagon tablets. These are tablets which used to be phenethylline tablets. Nowadays, they are mostly amphetamine tablets mixed with caffeine and some other products, and they are widely spread in the Near Middle East. Now, in terms of, we see here the amphetamine, but in addition, it's the methamphetamine which is increasing. So we don't have only an amphetamine problem there, we have an increasing methamphetamine problem, but as I said before, this is particularly linked to Afghanistan and Iran. And here we see the Captagon tablets. We see particular production sites taking place in Lebanon, in Syria, and then from there being spread around, very often either directly to Saudi Arabia, and the Gulf countries are the final destination countries, but it's also not going directly, it's also going sometimes via Europe, to Europe and back then to Saudi Arabia, sometimes in big shipments. So there's a big issue. And sometimes what we have, of course, a problem here is, as you may know, in Saudi Arabia, there's the death penalty. And having the death penalty, there are many countries who do not cooperate with countries which have the death penalty. So actually having the death penalty is helping drug traffickers. So we are really, as the UN, clearly opposing the death penalty in connection with drug trafficking. So we have made it clear several times, and really this actually helps drug traffickers to expand, and we see this clearly being the case in countries on the Arabian Peninsula. Now coming ecstasy, on the ecstasy market, we have seen sometimes a decline after 2007, then again a clear increase. Why? Because originally the precursor chemicals had been well controlled in China, but now the laboratories, particularly laboratories in Europe, have identified new precursors, pre-precursors, out of them to produce the ecstasy. And you see over the last couple of years, a clear increase in ecstasy, but the concentration here is still in Europe and on Europe. Only for 2020, we also describe in the report, there has been a clear decline in the ecstasy market, but until 2019, there was a trend clearly upwards. And in terms of big markets, apart from Europe, it is then Oceania, 20%, and Asia for 12%. So almost a third Oceania and Asia of the global ecstasy market. In terms of, again, the seizures, the biggest countries here in Australia, among the big ones, United States, Turkey, Australia, and also rather big New Zealand. Among the Asian countries, there is for ecstasy, it's Indonesia and Malaysia, which are important. In terms of the country of departure, the bulk is Europe. Almost 70% of the ecstasy departs from Europe. And the two biggest are the Netherlands and Belgium. When it comes to Asia, there's basically only a few countries, is Malaysia and China, which have been reported as countries of origin, but the bulk is Europe. It's not Asia, it is Europe. In terms of cocaine, Asia doesn't play a big role. There's only, this is Colombia, United States, there's only one, is Malaysia, where the big seizure took place in 2019, but it was not for Malaysia, it was actually for Australia. It was on the way from South America via Malaysia to Australia, and it was seized in Malaysia. And so this shows up. Overall contribution, you see the big seizures take place of cocaine in South America, then comes North America and Europe. The others is just less, just 2%, but among the others, the biggest are Asia, followed by Africa. Cannabis, when it comes to Asia, cannabis is grown everywhere, we said, particularly in the near Middle East. We have 3 countries of importance. This is Afghanistan, Lebanon, and Pakistan. When it comes to Central Asia, it's Kyrgyzstan and Kazakhstan. In Transcaucasia, it's Azerbaijan and Armenia. In South Asia, India and Nepal. And in Southeast Asia, it's the Philippines, Laos, Thailand, and Indonesia. And in Oceania, it's clearly Australia and New Zealand. In terms of the quantity seized, there has been a decline, but this decline is a kind of a statistical artifact. It's linked to the legalization of cannabis in North America in several jurisdictions, and thus clearly declining trend there. If you take out North America, there still would have been an increase, not a strong increase, but some increase. In terms of the countries, the biggest is United States, followed by Paraguay in terms of seizing. But in terms of Asian countries, the biggest is India, as you can see, and then followed by Pakistan and Bangladesh. So these are in Asia where cannabis herb plays a role. In terms of cannabis raising, Asia is much more important. Yes, the biggest is Spain, where it's getting from Morocco, but then Afghanistan, Pakistan, and Iran play a very important role. And when it comes from where does it come from, it's clearly number 1 is Morocco, but number 2 in the world is Afghanistan. So there is where the cannabis raising, the hashish, is coming from. And then also some importance is Kyrgyzstan. In terms of the upward trend, you see overall long-term, for many years, it was Europe. Europe has lost in importance. It's been kind of stabilizing, fluctuating. Although last few years, the increase was particularly in near Middle East, Southwest Asia, and partly also in North Africa, where the seizures have increased. And this is why I want to end now and ready for any questions you may have. Thank you very much.
Thank you so much, Thomas. That's fantastic. And yeah, really useful dive into what the data shows us from that region. And we'll come back to you, Thomas, in a few moments to do the same for Europe as well. So without further ado, because we are running slightly late because of the difficulties with translation, but we did an open call, as we always do at the Vienna Committee on Drugs. We did an open call to select some speakers from NGOs. And I'm really pleased that we have 2 excellent speakers who are both going to be speaking from the Asia Pacific region and to give some context and follow up on what we've heard from UNODC. Just quickly to say that our colleague Katerina from the Civil Society Unit at UNODC has incredibly bravely and incredibly kindly offered to jump into the Russian translation channel and is now providing some translation for us. So thank you so much, Katerina, for doing this. It's hugely appreciated. And I apologize once again for the difficulties we've had with the Russian translation today. So without further ado, it's my great pleasure to hand over to Dr. Hakimullah Saleh from the Afghanistan Green Crescent organization, who is going to tell us a bit more about their work and how they use and act, kind of act upon the data that is provided in the World Drug Reports. So Dr. Saleh, over to you, please. Thank you.
Thanks, Jamie. You are hearing clearly? You hear me clearly? Yeah. Hello, everyone. I'm Dr. Hakimullah Saleh, the president of Afghanistan Green Crescent organization from Afghanistan. I would like to thank you for joining us in today's webinar meeting. It's my pleasure that we have here honorable personalities from different countries during this COVID-19 pandemic. I hope that everyone will be safe from this problem. As you know, that Afghanistan Green Crescent organization is the only organization that they are working as a voluntarily from the director of it up to which we have more than 1,000 volunteers in all over countries and all provinces of Afghanistan. And we are working voluntarily for prevention of drugs and awareness about drug prevention. We are seek to promote the greater awareness on addiction, specifically in drug and tobacco addiction, with other national threats. You know that our country problem, poverty, climate changes, and presence of war since 40 years. As Mr. Thomas introduced Afghanistan, that one of the biggest country that we produce the opiates, and more than 80% of opiates of the world is produced from Afghanistan. And so this is the big problem from us, that we are as a civil society still did our responsibilities that how to prevent, because this is the biggest issue in our country, beside the war in our country, unfortunately. Still in our country, the presence of opiates, instead of that, we have the biggest problem is in our young generations, especially students. Beside that, the biggest issue beside opiate addiction, other drug addiction, and cannabis addiction is the pregabalin, tramadol, and ecstasy addiction is the biggest issue among the students of the schools and universities, unfortunately. As a civil society, still we made a big network between civil societies in our country, and also with we also mobilize the masjids and mosque mullahs, scholars, religious leaders in our country, how we aware people, especially the young generation, to not use these accessible drugs like pregabalin, tramadol, and ecstasy, and also opiates as well. First, I would like to present a little information about our country, that you know, Afghanistan, from the recent study which is done by UNODC and also by the INL, that in this the first survey was done by UNODC in 2005, that we had about 920,000 drug users in our country. But when the second survey have been done in 2009, it increased up to more than 940,000. You know that how it increased from 2005 up to 2009. And also about the other surveys which is done by in 11 provinces of Afghanistan, and out of 34 provinces, by INL, they had a household survey. We have about 1.3 up to 1.6 million drug users in our country. And the recent survey, which is done also by INL in 15 provinces of Afghanistan, and 52 villages of Afghanistan, it about 2.9 up to 3.5 million people of our population, unfortunately, they are addicted or they are drug users. It means that more than 11% of our population are addicted. One of these drugs, also opium use, heroin, and cannabis. Also, we have more than a million of female drug users in our country, and also children use. This is the big problem that you know that in our country, unfortunately, in our country, that still the historical misperception about the drug use, they don't know the harm of the drugs remain in our country. The drug is used by our population for the treatment of illnesses, unfortunately, in the local areas, for the relief of the pains, and eliminate psychological stresses and depression and sadness, and also sometimes they are used in the gatherings for the enjoy to the pleasure, especially among the youngest people. This is the big problem in our country. The estimated population in our country, the drug positive users is 2.9 up to 3.5 drug positive users. and drug user is 2 up to 2.4 million people. Among these, there are 1.9 up to 2.3 are adults, and about 1 million up to 1.2 million are children. This is the biggest problem that if we compare with other countries. Also, what is the factors that driving use the people drugs? There are some factors why more of our population are drug users or addicted. The main issue is the easy access to the cheap drugs, because you know that more than 80% of drug produced from Afghanistan. So it's very cheap in Afghanistan than other countries. The second is peer pressure, because you know that the people of Afghanistan are social people. They live together, they working together, and they are very good. Sometimes they become the peer pressure that one person use that drugs. They encourage the other friends, or they want to become addicted. And also limited access to drug treatment in our country, war-related traumas, the other factors, exposure to the drug use of the refugees. You know that in the 40-year war in the country, every day we have more displaced population in our country. And also exposure to the drug use of refugee. Economic issue, poverty is the biggest issue in our country, beside the war and beside that the addiction, and also joblessness, recreational purpose, depression and medical problems, psychological problem, psychiatric problem, and direct involvement with drug production. Now, what have government and our people stand against the current situation? Still, for the drug treatment and HIV prevention treatment, in care of national priorities, we in our country and our government developed a drug control law, and also national drug control strategy, national drug demand reduction and policy, and drug treatment guidelines, and drug prevention and education guidelines. Still, we have in our country prevention services and also the treatment services. We have different sites and different societies and different locations, the different kind of the drug prevention policies. For example, awareness program and some gatherings, social events, gathering, outreach programs, and sharing information of drug users for their family, and also the mask-based. This is the very important the rule of in our country, that people most accept whatever our scholars or our religious leaders says to the people. When they pass the message from their side, it's very effective among the people. And also youth congresses, gathering from in the schools, in the universities, and also vocational training. Still, we have done with government about more than millions of individuals benefit from such awareness interventions. Beside that, in our country, there is treatment services. Drug treatment services are provided publicly and privately, both by civil societies and by government. And also the Ministry of Public Health implements the majority of treatment service in the country, in all over the provinces of Afghanistan. There are estimated about 1,260 clinical staff providing drug prevention and treatment services through the UNODC and INL and MOPH of Afghanistan. The main donor and responsible for the drug treatment is INL, Government of Afghanistan, and Government of Japan, Germany, Sweden, Norway, and other small projects by the donors. We have in Afghanistan about 84 centers for the treatment, and 32 out of 34 provinces in Afghanistan. And among these 84 center of treatment, 8 are implemented by NGOs, different NGOs, and also and the other is implemented by the government of Afghanistan. Beside that, during the COVID-19 outbreaks, the government of Afghanistan is established about 4 other shelters for the COVID-19 affected addicts in the boundaries of the Iran and Afghanistan, in those provinces which are located in the boundary of Iran and Pakistan.
Just 1 minute, Dr. Saleh, please.
Yeah.
Thank you.
So the harm reduction services are testing and counseling the HIV-based needle insulin program. We have the condom program, prevention and treatment and sexual transmitted infection program, IEC and BCC according to the standard of material, referral for opioid substitution therapy in Afghanistan. We have diagnosis in viral hepatitis, referral for antiviral therapies, tuberculosis and other, provision of primary health care, and also provision of social services in our country. The future plan of our society is that we want to strengthen the prevention program, awareness program among the school and university students, and also establishment of training centers in every provinces of Afghanistan for volunteers that we have in our country, development of workforce for provision of quality services, reduction of drug use and related harm through awareness of social media, TV, radio channels, and also strengthening coordination mechanism in partnership with Ministry of Public Health and other related NGOs. Thank you very much.
Thank you so much, Dr. Saleh. That's fantastic. And yeah, obviously we'll have time, as I said at the end, we'll make sure we have time for questions. So again, welcome any of our participants to ask a question using the Q&A box if they'd like to ask Dr. Saleh any more information about the work of his organization. So without further ado, I'm very happy to hand over to Smriti Rana, who's from Pallium, India, who's going to talk to us today about the availability and accessibility of controlled medicines. So over to you. Thank you.
Thank you, Jamie. And many thanks to Sarah and to everybody at the VNGOC for having us. I want to just start by sharing a small story. 1 second. So in August 2016, this story hit the headlines in India. A man moved a lower court in a district seeking to euthanize his 4-year-old son who was suffering from uncontrolled pain. They visited 4 major cities in India, but did not receive any relief. Instead, they racked up a massive bill and were put in debt that was absolutely devastating. At the time, the palliative care community in South India tried to track the family's whereabouts and trace them to a hospital in Bangalore. A social worker from one of the palliative care organizations traveled overnight from Hyderabad with opioid analgesics prescribed by a pediatric palliative care physician, but those analgesics were never used by the hospital. And the child died in absolute agony. Over 97% of children between the ages of 0 and 19 in need of palliative care are in lower and middle income countries. The 1961 Single Convention places on us all a dual obligation to prevent the non-medical use of controlled substances, and equally to ensure availability of controlled substances for medical and scientific purposes. Of these 2 core imperatives, one is restrictive, seeking to limit access to controlled medicines and to prevent their manufacture, distribution, and possession for recreation and entertainment. The other is an enabling tenet to ensure that people who need these medicines to relieve their suffering are not denied it. We are obliged to prevent addiction and to treat pain. The system, though, is still effectively built around control and not access. The 2016 UNGAS declaration clearly addresses availability and affordability issues. And the problem is well known and acknowledged by the report. And it is predominantly that of low and low middle income countries, where the availability of internationally controlled drugs for medical and scientific purposes, including for the relief of pain and suffering, remains low to non-existent. The Lancet Commission for Palliative Care and Pain Relief report of 2017 called this a medical, public health, and moral failing and a travesty of justice. There is an estimated 15 million people in Southeast Asia who are experiencing severe, persistent pain and suffering. The UNGAS 2016 report highlighted the need to enhance efforts and cooperation at all levels to promote measures to ensure opioid availability and accessibility for medical and scientific use. But we cannot deny that these barriers to access run very, very deep. And major access gaps continue to exist, and not least the lack of training of medical professionals in the safe and effective use of opioids for pain relief. Misconceptions around the safe use of oral morphine abound, but we are yet to see any sort of comprehensive campaign to correct that misinformation. And there's this unjustifiable barrier caused by tedious, complex, and frankly, very unrealistic amounts of paperwork that make it near impossible for practitioners to effectively incorporate the use of opioid analgesics into their practice. Additionally, the cost of essential medicines is much higher in lower and lower middle income countries. There exists this paradoxical situation in these countries in which expensive opioid medicines and their formulations are the only ones available, while low cost, immediate release morphine continues to be unavailable or difficult to access. Now, in the absence of access to low cost formulations of opioids for medical use, high cost formulations like fentanyl, transdermal patches are not just prescribed, but also promoted, in spite of belonging to the same class and covered by the same regulations. If the patient cannot afford those, they are then pushed into the overuse of other less effective medicines. And self-medication with over-the-counter prescription drugs becomes a huge issue. And actually, quite alarmingly, even doctors end up prescribing medicines with terrible side effects, like pentazocine, that even though is a synthesized opioid, is not the most appropriate for non-acute use. And all of this effectively just adds to the experience of suffering. So why does this happen? Because in prescribing these, practitioners do not have to contend with the damning narratives that morphine and other opioids are subjected to. In 2015, a WHO-backed study estimated that the average morphine equivalence, which is a proxy indicator of a country's palliative care provision, was only 1.7 milligrams per capita in Asia, compared with the global average of 61.5 milligrams per capita, which pegs Asia's morphine per capita consumption at 36 times less than the global average. At this point also, I just want to quickly show you a map which clearly illustrates the massive variation in the ways opioid analgesics for pain relief are accessed by different parts of the world, and the estimated percentages of the needs met. Countries, entire countries have just disappeared on this map. And this is a pretty telling snapshot of what disparities exist. Opiophobia, which is the prejudice and misinformation about appropriate medical use of opioids, remains a major issue. And this opiophobia is exacerbated by the singular focus on inappropriate use, which by all means is a tremendously important issue, but certainly not adequately evened out by available evidence of successful achievement of balance, which is something that we should be looking towards as models. There are several examples where the principle of balance has been successfully achieved, and a common denominator underscoring these examples is partnership between governments and civil society actors. Perhaps the easiest and most well-known example is that of the southern India state of Kerala, where we come from, and where the government was particularly sensitive to the public demand for pain relief. And through the state palliative care policy, which came up in 2008, possibly the first policy of its kind, the government enabled people to receive palliative care, including the supply of morphine, to their homes, giving them access where they needed it, when they needed it. And this policy has since undergone a revision in 2019 for further improvements. A detailed study had been done in Kerala as far back as 2002 to see if there was any diversion or inappropriate use of opioid analgesics. 175 licensed facilities report to the state drug controller, and he investigates any suspicious trends. From 2002 till 2021, there has not been even one reported case of diversion or misappropriate use. Outside Kerala, we find another remarkable model of that's developing right now in the nearby state of Telangana, where a cohesive partnership between civil society and government has resulted in 33 districts getting access to palliative care and pain relief in the form of home care, inpatient facilities, and capacity building for frontline workers. And it is a real shining example of the government inviting the expertise and knowledge of civil society groups and leveraging its own mighty infrastructure to translate this expertise into practical addressing of suffering. So pursuant to the war on drugs approach that emerged in the 60s, 70s, and 80s, several countries adopted highly restrictive policies for control. And this rhetoric has been interpreted in ways that has frankly been quite reductive and harmful in some places. In India, for example, it led to the highly prohibitive Narcotic Drugs and Psychotropic Substances Act of 1985, which stipulated very harsh punishment, punitive action for even minor clerical errors in hospitals that were stocking opioids. And it took decades of efforts from civil society before landmark amendments were finally made in 2014. But 7 years on, these amendments have still not been implemented in the majority of Indian states. The UNGAS outcome document explicitly reaffirms member states' determination to help to ensure that all people can live in health, dignity, and peace. And health is defined by the WHO as not just the absence of disease and infirmity, but also the presence of well-being. But how is true health or dignity, peace, or well-being to exist in the presence of unmitigated pain? So contrary to perception, it's not easy for countries to raise their imports. And so a system of manufacturing low-cost medicines and develop a supply for their availability in low and middle-income countries can overcome the most important barrier to opioid access. And we ask that the Commission on Narcotic Drugs ensures a fit-for-purpose supply chain for controlled medicines in the future, both for COVID and for patients with other palliative care needs. If we are to achieve the principle of balance, then the needle needs to be moved so that the weight of these arguments equally addresses mitigation of unnecessary suffering. And how do we move the needle? Policies of countries are influenced by documents like the World Drug Report. It is a responsibility and a moral obligation whose foundations go back to the Single Convention to give equal importance to control as well as to access. What we need now more than ever are well-calibrated, smart regulatory systems that maintain at its very heart the overarching goals of the United Nations to protect health and human rights. So we seek from you a response to this urgent need for a smart regulation to increase access to opioid medications for medical and scientific use, while providing the additional guardrails of proper training, appropriate evidence-based information about the safe use of opioids for pain relief. As an individual who has had a ringside view to both addiction and excruciating pain in my family and in my community, I seek from those present here today the consideration that if there is a war to be waged, let it be on suffering then. Thank you. I'll stop with that.
Thank you so much, Smriti. I really appreciate your intervention today. It's a really important perspective, which, as the Vienna Committee on Drugs, we've always been really keen to make sure that the voices of the palliative care community are heard as well. So thank you. Okay, so I'd like to come back now to Thomas, who is going to give us a brief presentation of the summary of the data from Europe. And then immediately after that, we will make time for the Q&A. And again, please do submit your questions so we can see those in advance. I don't know, Thomas and Chloe, I don't know if you're able to see the Q&A box, but there's also the opportunity to answer some of the questions in writing, if that's possible, if they're easy to answer in writing. But we'll try and make sure we have time for them all at the end, even if we do run slightly over the advertised time. Again, sorry for the delay, but it was mainly caused by that confusion around the translation. So Thomas, over to you, please. Thank you so much.
Thank you very much. Now, again, I hope I'm still. How is it now? Do you see the presentation?
Nothing yet. I can just see you.
Oh my God.
I'll let you know when that changes, Thomas.
Now? Do you see my presentation? No? Hello?
No, I can't see it, Thomas. I can only see you still.
What should I do? Sorry, I apologize. This is just my, each time I say share screen, Sorry, one more time. I say share screen, and then I go to the presentation to one, and I say, you see something.
It's not working from my side. Are you able to maybe send the presentation to Sarah or someone so we can try and share it from our side?
Again, what are you sharing?
Oh, here we are.
Can you just, again, it cannot be possible. Why?
It just came up. Yeah, I can see your screen now, but just
Okay,
not the slides so much.
And do you see it now?
Yeah, we're good. We're good.
Oh,
Thomas, thank
finally.
you so
Sorry,
much.
I apologize for this. Okay, Europe, cocaine. Cocaine, we know it's come from the Andean countries. The main trafficking route is from the Andean countries to North America, but there's an important trafficking going on from Andean country to Europe, either directly, basically to Western Europe. So we're speaking here of Belgium, we're speaking of the Netherlands, we're speaking of Belgium, of Spain and Portugal as main entry points, but there are many, many others. It also goes indirectly to Brazil, and from Brazil then to Europe, or it goes from Brazil to Africa and from Africa to Europe. And even in Europe, we have all kind of trafficking back and forth. We have trafficking to Europe, to Africa, and back to Europe. So it's really a multitude of trafficking activities in this part. Now, in terms of in yellow, you see the cocaine manufacture in Colombia, in green, in Peru and Bolivia. And what you could see in the last couple of years, a massive increase in cocaine production. In red, you see the prevalence rates in the United States, and somehow it followed the changes in production. However, when you take the global cocaine manufacture, it increased by 64%, while the US prevalence rates of cocaine increased by 33%. So what does it mean? Yes, US has taken up some of the extra cocaine, but not all of it. And where else has it been going? To the whole world, including the other countries in South America, including to Europe, including to Asia and many other parts of the world. Now, in terms of, we have the wastewater analysis in Europe, and what you see is a massive increase between 2011 and 2019, only declining slightly in 2020. So the increase was there 56%. When there was a missing data, we assumed there was no change. We did the same thing, a weighted average. It's again a 56% increase. The only difference is in 2020, we didn't see a change, basically because in large cities in Europe, you still had cocaine available, and only in small cities, there was a decline. So there was a real difference between small cities and large cities. Large cities availability was there and consumption was there. Now we have another indicator, which is done mathematically a little slightly different, only the cities reporting the wastewater, and we compare those, and you see there was more a doubling in the quantities seized. What does it mean? Anything between 100+50% and 120% is a possibility, and it's clearly higher than in North America. So the increase of cocaine in Europe was clearly higher than in North America. This is the bottom line, what it says here. Now, in terms of the quantities, most have seized in South America, then 90% North America, 15% in Western Europe. And for Europe, as I said before, big countries of entrance are Belgium, the Netherlands, and Spain, where there is clearly a concentration. There's something else what we found in the World Drug Report. It is that the purity levels used to be much higher purity of cocaine in North America and United States, much lower in Europe. However, since 2011, 2012, it has been almost identical, and you see an upward trend. So it means more supply gives you higher purity levels, but it's the same in North America, it's the same in Europe. So this is something also a new phenomenon which we discuss in the World Drug Report. In terms of the opioids, I discussed before, the big for Europe, the big source is Afghanistan for the opium being trafficked along the Balkan route. However, this doesn't mean other routes exist as well. We have trafficking by a so-called southern route, which goes from Africa and from Africa afterwards to Europe. And we have trafficking across the northern route, which means Central Asia, then through the territory of the Russian Federation and into Europe, West and Central Europe. We had a number of big cases there in the last couple of years. What's interesting is in these cases, very often people from outside the area had been involved. So you had people, you had Turks people involved, you had West Europeans being involved in this trafficking activities. So also non-people from not Central Asia and not Russia. So using, however, this northern route. Again, this was up to 2019, it was big. 2020, it really declined. We have not seen such cases 2020. So the pandemic, the COVID pandemic really meant this trafficking to the northern route clearly declined. And what we have is ongoing trafficking through the Balkan route, but also Balkan route trafficking. It was big Pakistan, big to Iran, but thereafter it declined. So we see really in Europe was affected by these shutdowns which existed. However, what we have also seen, there was an increase in the maritime trafficking taking place, where they tried via the maritime means to get the heroin to Europe. And we said already before, the biggest seizures in heroin, morphine are Asia, but then it's followed already second by Europe. So number 2 is Europe and only then the Americas. But really Europe is important. And within Europe, it's important is Southeast Europe, which means Turkey in particularly, and then comes Western and Central Europe. In Europe, you see something interesting from 2016 onwards, the massive increase in seizures, which also means more heroin being flooded on the market. We have not seen it so much in the consumers. So we have not seen that there are so much increase in consumers. So far, it has been a supply push. And supply push mostly linked to the big harvest in Afghanistan in 2017, which gradually moves onwards to Europe. Again, the bad news up to 2019, the good news 2020, we did not see this. However, this could have been a temporary phenomenon, and we expect this to disappear again very, very soon. As I discussed before, the biggest seizures of heroin in Turkey, but then you have Belgium. The other countries in Europe are not playing so much of a role. It is really just Turkey, and then comes the Asian countries, which are of importance. We said before the availability. So Europe is Western Europe is number 3 after North America, Australia, and New Zealand in terms of the availability of the preparations, medical consumption of opiates. But then far below is Southeastern Europe. So we have rather high levels still in Western and Central Europe, and already below average levels in Southeastern Europe, and already very low levels in Eastern Europe. So there's within Europe a quite big difference of availability of pain medication between Western Europe, Southeastern Europe, and low in Eastern Europe. So we have this for Europe. Over the last few years, there was a small decline in the availability of opiates. And you see in Southeastern Europe and Eastern Europe, there was basically an increase from 2015 onwards. Even so, 2018, 2019, there was a small decline, but it's much, much lower. So this, so in terms of the global amounts of opiates, you see in the last couple of years, the only thing which increased was the methadone and the buprenorphine. The others really have declined. And now we look to methadone and buprenorphine. And again, Western Europe is number 3 after North America and Australia and New Zealand. Western Europe it is mostly the methadone, less so the buprenorphine. And then you have Southeastern Europe and extremely low Eastern Europe. So you see the differentiation even more. So methadone is very, very little available in Eastern Europe for treatment of heroin addicts there. So there's quite a discrepancy between Western Europe and Eastern Europe, even though we speak about Europe. In terms of the quantity seized, amphetamine clearly increased, but also we have seen an increase in methamphetamine. Look in wastewater consumption, it is also clear the amphetamine is more important than the methamphetamine. The increase was clearly up to 2019. In 2020, there was a decline in methamphetamine consumption in Europe, while amphetamine consumption basically stabilized. In terms of ecstasy, Europe, as told before, Europe is the center of production of trafficking of ecstasy. In the last few years, we have seen again an increase. Why? Because the ecstasy laboratories in Europe have identified new precursor chemicals where they can produce it out of precursors. They can produce the ecstasy. But you also see it's not only Western and Central Europe, the original part, it's now also Southeastern Europe, which plays an important part in terms of ecstasy production and trafficking. Overall, Western Europe, Southeastern Europe, and Eastern Europe together are responsible for 42% of global seizures of ecstasy. So the market is really there. Also in terms of wastewater, whatever the indicator is, what we used, we see there was a massive increase from 2011 to 2019, followed by a decline in 2020. In terms of cannabis, there has been an increase in cannabis, globally cannabis cultivation, particularly in indoor cannabis. And indoor cannabis is something which affects Europe. So indoor cannabis is clearly increasing. And in Europe, countries of major production in terms of cannabis are the Netherlands, Spain, and Albania. In Western Europe, for Southeastern Europe, it's Albania and Serbia. And for Eastern Europe, it's the Russian Federation, Ukraine, and Kazakhstan. In terms of cannabis use, there was a kind of the good news that basically among 15 to 16 years old, cannabis use since 2011, even since 2007, stayed basically the same, not much different. Now compare this to the United States, where you clearly saw an increase, particularly after 2015. But the increase in the United States has been not so much in the annual or lifetime prevalence. It really has been massive in the daily prevalence. So the cannabis use is massively increasing there on the daily side. And this is the problematic one, not somebody who takes a joint once a year. It's really the persons who take it on a daily basis. And this is what increased massively in the United States. And we also would see, if we don't the youth population, but the adult population, we see a far bigger increase in consumption among the daily users than among annual or past months prevalence. So massive increases in the United States on this daily use. And this is something which is a real concern for us. We see here the daily use, which is the most of concern. And this is where the biggest increase is. Normally, we only look at annual prevalence, but this time really should look also at daily or near daily use. Now, last words on the dark web. You see on the dark web, European countries have been involved. Particularly high seems to have been the involvement in the Russian Federation of dark web trafficking, but also in the Nordic countries. Finland and Sweden are very high levels, but also the United Kingdom. Everywhere in the world, it has increased over from 2014 to 2020 or 2021, and you gradually see a clear increase. This is now people directly being asked, have you purchased drugs over the dark web? Now we have a different method where there's a web crawler, where we look actually what is being sold on the darknet. And here you see that over the 2011-2020 period, the biggest sales transactions over the dark web regarding drugs took place in Europe. The number, even so the single biggest country selling drugs is the United States. But overall, Europe is the biggest. It's started by the United Kingdom, followed then by Germany and the Netherlands. And even this is not full because actually the Russian Federation is missing here. Why? Because in the Russian Federation, most of it's sold by the Hydra market. And on the Hydra market, there people don't tell you from where it's being shipped. This is all information from where it's being shipped. So Europe is underrepresented here, but you see already a big importance of Europe. Now we see again, Chloe showed already over the last few years, the changes. And what is interesting here is there was the Dream market, which was dismantled, stopped operating. But the biggest market in 2020 was Hydra market. And the Hydra market is the market serving the Russian Federation or the Russian-speaking countries worldwide. So suddenly, for the first time in 2020, the biggest darknet market in the world was Hydra market, the market for Russian-speaking people. Still big is also Cannason. Cannason is basically a market for cannabis. Empire was important, but Empire stopped its operation as of August 2020. So what does it mean now in terms of changes? In terms of changes, you see an increase starting from 2019, particularly strong in the second quarter of 2020, when we had the shutdowns in Europe and also many other parts of the world. And you see in terms of the products, you see there was a fourfold increase in the sales over the darknet from 2019 to 2020. And particularly strong it was for cannabis. There was a fivefold increase, but also an almost fivefold increase for stimulants and for cocaine, a threefold increase for opioids. In contrast, there was a decline on NPS, and which we don't have here on the list. Ecstasy also declined. Ecstasy declined around 25%. So we have a differentiation, but overall, darknet has benefited from the COVID pandemic. This we can say, and in particular strong was the cannabis over the darknet. And this is what I wanted to tell you. Thank you very much.
Thank you so much, Thomas. So thank you everyone for bearing with us. And I can see that even though we've gone slightly over the scheduled time, we still have more than 150 people with us on the webinar, which is fantastic. So thank you everyone for your patience and for sticking with us. So I think we have some time now to address some of the questions that have been raised. So looking at the ones that I have submitted in front of me, I think I'll split them into two different batches and ask Chloe and Thomas to respond. And then Smitri and Dr. Sally, you can maybe raise your hands or let me know if you also want to come in on these. So I think the first one, there was a group of questions. The first one really more of a statement, which I'm sure the research branch will be fully agreeing with. So it's from Christina from Sperling Afridi in Pakistan. In many countries, including Pakistan, there has not been any survey conducted since 2012, published in 2013 about the prevalence of drugs. It would not be possible to share global statistics. Can we ask all the stakeholders to ensure that they conduct surveys on a regular basis so that we have more accurate data? So I think it would be great to comment on that. And then Chloe, I can see that you've been answering some, but just for the sake of those who aren't following the Q&A box, there was also a question on the impact of COVID on, in terms of disruptions to addiction treatment, and also a question about why the report doesn't mention decriminalization. So it'd be great if I know you've answered those in text, but it'd be great if you could, for the translation as well, if you could answer those questions very quickly. So we'll take those three first. The importance of up-to-date data at the country level, the impact of COVID on treatment disruptions, and the coverage of decriminalization policies in the report. So over to you. Thank you.
Thank you, Jimmy. So on the importance of up-to-date data, yes, we only concur with that. Just for the person, I don't know who made this comment about Pakistan, but for you to know that we are conducting now a national drug use survey in Pakistan. So there will be an update, hopefully. I don't know when, because it takes time. Just for you to understand, we do a lot of capacity building with the countries who are interested, and when there is funding, of course. So we both work with countries and with donors to develop the tools and to implement the best methodologies to try to estimate drug use in a country with different methods, direct, indirect, etc. And not only drug use, also problematic drug use. Now, in Pakistan, it's on the way, okay. A new estimate. Okay, now the question on what was it? Addiction treatment during the COVID. So perhaps as I mentioned in my presentation, and I invite you to look at booklet 5 of the World Drug Report, there is a chapter on this. Basically what happens is that at the beginning of the pandemic, there was clearly disruption in terms of the delivery of drug services to people who use drugs. And but then after a while, quite rapidly, in fact, there was an adaptation, at least in some countries. I'm not saying all of them, but many countries have reported to us some innovations. So with telemedicine, also with the dispensation of opioid substitution treatment in a different way, a take home, etc. So all is in the booklet, and I invite you to go there for perhaps more details. So this is good news. At the same time, what I mentioned, I would like to highlight here is that there are good ideas here that we need to assess now in terms of to see how and if they need to be mainstreamed in the post-COVID phase, basically. So this was during this emergency period, I would say. But now we need to see whether there are good ideas that could be mainstreamed, but they need to be evaluated scientifically, of course, because there are pros and cons. And then the last question was about the decriminalization. Well, the World Drug Report is mainly focuses on giving how to say, a state of the situation regarding drug supply and drug demand, or drug markets at global level and in the region and sub-region. Now, there are an infinite number of policy options, I would say, regarding drugs and drug activities. And in the spectrum, I would say, between full prohibition and full legalization. They're really an infinite number. And all these policy options also can be implemented in different ways too. So it's not only what is on paper, it's only what is done. Now, if we want to provide, if anyone wants to provide a serious assessment, a serious account of these policy options, including what we call decriminalization, but decriminalization here would stop to say, this is a very broad term, is an umbrella that may cover a number of policy options too. So we need also to perhaps to disentangle this first. So if one would like to give a serious account of these different options, including decriminalization, and then look at the impact on drug markets, but this is a comprehensive study in itself that need to be carried out at a global level and in different countries, etc. That goes much beyond the resources of the World Drug Report. So we are not there yet, but there is the annual report questionnaire. So for some of you, I don't know if you're aware, so this is one of the main data collection instruments behind the World Drug Report, which the member states fill in every year. This IRQ, the IRQ has been revised in the last 2 years and is being implemented for the first time in 2021. So for next World Drug Report, we will rely on some of this data. And there is a module in the new IRQ which looked at drug policy and implementation. So
okay,
hopefully we will look at some of these issues in the future.
Okay, fantastic. Thank you so much. So I'm going to try and merge a few questions together because I'm conscious of time as well, Chloe. And thank you for you and Thomas for staying on as well. So we have a couple of questions which are from Fiji and Oceania in particular. And they're asking about what do we know about the experiences in terms of materials that are used to make meth in Asia and Oceania. So I'm assuming precursors and other materials. But also, do we have enough data from Oceania and in particular from Fiji, and what technical support is available, it says in particularly in terms of finance, available to civil society organizations in that part of the world in order to try and plug the gaps? So I don't know, Chloe, yeah, over to you.
I can let Thomas answer on the starting material for manufacturing methamphetamine. And I mean, the rest, Thomas also can answer, because I think, Thomas, you would know who is submitting IRQs to us or not. I'm not sure we receive so many IRQs from this area. Thank you.
Yeah, so over to you, Thomas, please. Thank you.
Yeah, regarding the starting material, we have basically ephedrine, pseudoephedrine, starting from methamphetamine. The P2P is still the exception. So we have the P2P, we have it in Mexico, we have it basically in North America and some parts of Western Europe, where you have P2P and the precursor of P2P. There was one exception here, was in Vietnam. But this is more sophisticated. So the easier way of doing it is ephedrine, pseudoephedrine. You take preparations, pills, over-the-counter pills. You smash them and you use them as the raw material for the methamphetamine production. So this is what you have in this part of the world. Regarding the other question of source of information, is extremely poor in the Oceania. So except Australia and New Zealand, it's extremely poor. We hardly get any information from these countries. So we have only secondary information. Very often this is outdated, we have to say. So very limited information. We get sometimes some seizure reports of the country. So we know what's have an idea what is happening, but definitely there's lots of needs of improvement.
Okay, thank you. And in terms of like capacity building, financial support for civil society organizations in that region, is there any program available at the moment, or is it really dependent on what funding UNODC can also find itself?
Okay, I know for years there has been some funding made available from Australia for this part of the world, but again, it has been limited. But I know there's efforts, particularly from Australia, who are interested in this region. We don't see interest from other countries.
Okay, thank you. Okay, so last batch of questions. We've got a few questions from India, from Rajagopal. I hope, apologies if I pronounce names wrong. But asking, is there any evidence that banning the soft drugs like cannabis seems to lead to the introduction of hard drugs on the streets? But also, does UNODC formally accept the principle of balance that Smriti talked about in her intervention, but our efforts should be to prevent suffering, both from addiction and unrelieved pain? So I guess one of them, yeah, that second part is really a follow-up to Smriti's presentation as well. And then just another quick clarification was around any data that might exist on comorbidity between drug addiction and drug-related problems and other diseases. Is that something that the World Drug Report also looks at? So it'd be great. I think that will be the last round of questions, Chloe, if that's okay with you.
So very quickly, yes. I mean, you have to go to different World Drug Reports to get an answer on the comorbidity. And depending on the years, yes, we have provided some answers to that. So I invite you to look at previous World Drug Reports, and some are very rich in terms of looking, yes, at the comorbidity. What else? Yes, UNODC, we have mentioned various times in our policy implications the principle of finding the right balance between preventing, how to say it, the abuse of control medicines and the diversion of controlled medicine, and at the non-medical use, and at the same time ensuring that they are widely available. So this is very clear in all our policy implications of the World Drug Report. Yeah.
Perhaps regarding the question whether we have seen that, if I answered the question correctly, what the question was, if you legalize cannabis, if there will be more hard drug use. Was this the question?
The question is worded, I'll read it exactly just to make sure I'm representing it. It's, is there any evidence that banning soft drugs like cannabis seems to lead to introduction of hard drugs into the streets? So it's not about legalization, it's about the opposite, about prohibition.
No, I don't see any evidence in this regard. What there has been a kind of unforeseen consequence was when cannabis had been legalized in some of the states in the United States. Most of the cannabis before came from Mexico. Cannabis afterwards was to much larger extent produced in the United States, because in the United States you had a higher THC content very often than you had the cannabis coming from Mexico. So farmers in Mexico had problems to export their cannabis to the United States because the cannabis was produced in the United States and partly also in Canada, but it was produced in the United States. So, and now there was a reaction of some of the farmers that they shifted from producing cannabis to producing opium. And so the opium was then transformed into heroin, and this heroin was then exported to the United States. So this was a kind of nobody, I mean, I've seen many reports of predictions what could happen. Nobody had ever foreseen this to happen, but we had seen at least at some stage, an increase of opium production in Mexico, perhaps or partly linked to the decline of the cannabis market in the United States. Having said this, the latest reports what we got from Mexico was the opposite. We saw again a decline in opium production. So this was something which happened, but we don't see a continuation of this happening.
Yeah, and I guess it's such it's too early to be able to really.
Yes, I would be cautious about any conclusions on the impact of legalization. Yeah.
No, totally.
And also because it's implemented in so many different ways. Well, this is the comment I made before. You need first to understand exactly how it's implemented.
Yeah.
And then to try to see the impact, but this is not something easy to see.
No, that's noted. Thank you so much. So Like I said, we have gone over time, and thank you so much to everyone who's still with us. Like I said, we're still around 100.
One thing I would just make a comment to Miss Dr. Rana. I really liked the presentation, what you did, and I just would really like to confirm what you said. And I think one of the reasons we wrote it in the World Drug Report, we highlighted this discrepancy. We highlighted this discrepancy was exactly what you see, to alert people across the world that there is a completely unsafe balance in the world, that you have some regions like North America where you have enormous amount of such opioids being available and apparently being misused, and you have most of the developing countries where so little available, so many people have to suffer. So this is exactly the reason why we wrote this in the World Drug Report, why we wanted to highlight the international community about this and do something against it. So just to confirm, thank you for the presentation, but it's just what was the intention of the World Drug Report.
Yeah, that's much
appreciated. Thank you so much.
Thank you. Yeah, thank you. So, yeah, just to say from my side, thank you everyone for being with us today, and particularly to Chloe and Thomas and Hakimullah and Dimitri as well for your wonderful presentations today. For those of you who are thinking, well, why haven't they talked about Africa and why haven't they talked about the Americas? We have another webinar planned for Thursday. And it will follow the very similar format, and Thomas will then give us a more detailed summary of what's happening in those other regions. So I've just shared the link in the chat. It's at 4 p.m. Vienna time, and we will have translation into French and Spanish in that webinar to make that possible. And I think actually, Morelli, I can see your hand up, but I think we're also going to try and offer Russian as well. So, but just quickly from my side, before I hand over to Morella for the closing remarks, again, just to say thank you to our translators and thank you so much to our speakers. And just to flag, you may have seen it in the chat, but there's also in the workings, the Vienna NGO Committee also has an ad hoc working group focused on Asia and the Pacific to try and make sure that NGOs from that part of the world are engaged in the Vienna Committee's work. So there is there's a consultation plan, which an email will be sent out soon, but you'll see it in the chat. There's a consultation planned, I believe, for the 28th, I think, of July. So just, you know, a few weeks' time. So if you're interested, we'd love to see our NGO colleagues from that region of the world join us in that consultation. And the partners in that part of the world are working towards to see if we can put together a civil society common position for Asia and the Pacific. So just to flag that as well. So from my side, just to say thank you so much again. It's been a pleasure, really interesting presentations, and I happily give the floor to Morella for closing remarks.
Thank you, Jamie. Not really closing remark, considering it's almost 12, but just to thank all the participants. And again, very much regret that we were not able to provide the Russian interpretation like it was foreseen. We have wrote meanwhile to the company, and we have decided to add it to the session that is taking place on Thursday. We've put it in the chat, also the link. We will inform all the people who were only Russian speaker in the session today. It was a very interesting session, a lot of discussion, and thank you, Chloe, Thomas, and thank you to Katerina, my colleague who jumped in. She is not an interpreter, but she tried at least to make sure that something was understandable. Thank you to Sarah, close to me here in our hybrid format, and to everybody, whoever wants to join again on Thursday, you are welcome. Thank you, and bye, everybody.
Bye, everyone. Thank you very much.
Bye.